Welcome to the Strength and Chiro podcast. Introducing your hosts, Doctor of Chiropractic, Stephen Redmon, and powerlifting world champion, Brogan Williams. Join us as we explore evidence-based chiropractic and sports science through the lens of movement, strength, performance, and overall health.
All right, welcome to the podcast. How are we doing, man?
Not too bad. Yourself?
Yeah, pretty good. Had a pretty good weekend. It's Monday for me? Sunday for you?
Yeah, Sunday evening. I think it's like 7 o'clock. Yeah, 6:59 p.m.
And you've been renovating your office?
Yes.
Busy. Getting down to work. Plaster and paint everywhere. It's looking good though.
I think so.
It's coming together. Sweet. Well, a few things I want to talk about, especially since the last one. And before we move on, thank you to everyone that reached out after our last podcast. Obviously, it was just a conversation. We went too long. We probably waffled too many times. But both of us had heaps of positive feedback. I had lots of people slide into the DM and just people enjoyed listening to it, and lots of people we cranked up like thousands of views on the clips, especially which were on TikTok and Instagram and YouTube. So if you're interested in listening to this podcast, I mean, put it on your way to work, put it on your way to uni, whatever that's cool. We're going to try and keep it under an hour, but if you want to hear some of the main bits, I will be throwing up 3 to 4 1-minute clips, just kind of highlighting a few things. And that's Strength and Chiro on TikTok and on YouTube as well. And then it'll be on my account, which is Strength Science, which is on Instagram. So look out for that. We're going to cover a few things today. And then hopefully in the future, we're going to have a few guests on, lots of people that we would like to have on. And I even had quite a few people reach out who are interested to be on as well. So, hey, that'll be fun. Interview some people, hopefully that are smarter than us. Well, I'll speak for myself because I know that. I know some people call you the Tony Stark of chiropractic, or is it the Doctor Strange of chiropractic? You could always do the. You could always do the. I mean, his facial hair looks kind of similar to Tony Stark's, doesn't it? To be honest.
Yeah, pretty similar.
But he's got the white whisper, and I like the white whisper.
I got a little bit of that going on.
Yeah, I've just like had a haircut, but before that I had quite a bit of grey hair, and I'm just like, I don't mind it. I like back in the day, like
I don't mind the grey at all.
My wife and my mum are like, "Oh, you're going so grey," and they'll like hassle me about it, and I'm like, "Hey, it's wisdom. It's wisdom. Don't worry about it." Hey, before this turns into a Marvel podcast, which we probably easily could, because we both love Marvel, we'll get on and we'll have a chat about some stuff. One thing I want to talk about, which has interested me for a while now, is the importance of communicating with patients. The reason why I say this, and I suppose it is more specifically with chiros, because there is this kind of preconceived idea out there for those that are not educated or just don't know about it, that chiros are kind of like bone crunchers or people that just click. Well, like I've heard that a lot. People that don't understand it. Like with you being a chiro, when someone comes in to see you, how do you communicate around the treatment that you're about to provide? Because I know with me, I've heard lots of stories, even from family members, about people that have gone to see chiros, and they know that they crack backs, they know that they make pops and cracks and sounds, but they're not really sure, the method, the modalities, the philosophy, or the intention behind it, and the chiro doesn't do a good job communicating it. They go in, they have a very forceful adjustment. I mean, it's meant to be high velocity, low amplitude, but they have a very forceful adjustment. And then they're sore for the next few days. And then there's kind of this idea of, I went to a chiro, he cracked me, he smashed me, I was sore, I was worse, and then never go back. I've actually heard quite a few people have that experience. And I often say to them when they're talking to me about it, that's not like a modality or an intervention issue, or maybe it's an adjustment problem, but it's more likely a communication problem. Do you have any thoughts on that?
I honestly don't know that I do the best with communication. I'm sure that I could improve, always can improve in communication. But yeah, I I do believe that there is definitely a communication barrier, and that can lead to bad patient outcomes with manipulation in general.
Yeah.
Like, I had a patient, longtime patient, who I've been seeing even as a massage therapist, and he came in for an adjustment. He's a bigger guy. I used him on my typical table the first time, and he did say he was pretty sore. He's very familiar with manipulation, adjusting, and he's had it done plenty of times, but he's a bigger guy. And I had him on the larger table, and he told me that it didn't feel so great. And I was like, yeah, I don't even know why I used the larger table on you. I should have used the smaller table. So it's very good to have multiple ways to adjust the patient, whether it be a table that goes up and down, and able to realize when you should use which table. Typically, I do a pretty good job. This patient I hadn't seen in probably 4 or 5 years, and we just kind of like jumped straight into it because he was just really excited to see me for the first time in many years, and I wasn't even thinking about the fact that I knew that I needed to use different equipment on him. And I think that ultimately what it comes down to is a mixture of communication, miscommunication, or just absent communication on the chiro or the clinician's aspect, as well as just maybe being slightly absent-minded, maybe getting a little too comfortable with the patient. I know I mentioned to you before we even started the podcast about like the insane correlation with patients being a chiropractor and then having a stroke. It's typically not because the chiropractor caused a stroke, but because they were too comfortable with the patient, whether it be an existing patient or just being comfortable with those symptoms and just ruling out a stroke absent-mindedly instead of assessing them for a stroke or pre-stroke or vertebral artery dissection. I think that's what it ultimately comes down to, is just being absent-minded and not realizing where the patient's at mentally and where you're at mentally.
Yeah, it's I suppose the art of communicating is like anything else, right? It takes time to learn. Some people are natural at it, sure, but for a lot of people, It takes time to learn. And to kind of even move this into a coach's view or a personal trainer's view, you know, you can have, obviously the clinical aspect of it is very different. You know, you're not screening for strokes, but when it comes to communicating for someone, like, it's important, especially when someone has an idea, like they're wanting to put muscle on, or a lot of people have an unrealistic idea. A lot of young males have an unrealistic idea of how much muscle they can put on over a period of time. A lot of females have an idea of, oh, I don't want to get super bulky, or I don't want to look like this certain type of person. So communication around people's goals is incredibly important, and especially when you're dealing with things like, getting people to put their bodies through movements that they may not have done before, or you're asking someone to change what they're eating. If you're a nutrition coach, the communication aspect, regardless of the modality or regardless of the profession, is extremely important. And I suppose it comes down to the same thing. You can be sore after an adjustment, and if your chiropractor didn't tell you that might be a possibility, then that's gonna be a negative thing possibly in your mind. But I suppose it's the same thing with training. Like, when you're trying to correct someone's technique and they've been doing something wrong for a long time, trying to do things a better way, you're changing things with the musculoskeletal system. And so it's important to communicate what is expected. Otherwise, people can kind of see it as an adverse reaction when it's not. When really what it is it's a purposeful stimulus, hypertrophy training, or even if you're adjusting someone and you're taking a joint past that range, it's important. So no, I know what you're saying. Another interesting thing that I wanted to get your thoughts on, it's probably like years ago now that we started talking. We started chatting about chiropractic stuff, and in the world of where I am, my chiropractic world of being in Auckland, New Zealand, very different in certain ways to what you guys obviously are in the States. And I know the States is obviously, there's lots of different places there as well. But some of the interesting things for me was like the science or the understanding of what you're really doing when you adjust someone. And I was wondering if you could talk a little bit about, I suppose, specifically the tissue pool, right? Like the frictionless interface between the skin and the muscle and the bone. And obviously also like we've got some research on that. McGill's done some research on how you can't like hook onto bone when you're trying to adjust. This idea of like hyper-specific adjustments, like your thoughts on that, your thoughts on the tissue pool, and then also your thoughts on moving a bone versus gapping a joint in terms of like when you're adjusting somebody.
Yeah, I personally found McGill's research on the frictionless interface. I think it was of the lumbar spine, maybe the thoracic spine. I don't remember. It's been a while since I read that, but it was really interesting for me because when you think about it, even if like you look at the more philosophical based chiropractors, no one's really doing skin on skin. And in theory, you have to be skin on skin. Otherwise, obviously, someone's clothing alters the friction, and you can't lock in on whatever tissue or bony segment you think you're locking in onto. And just maybe 2 or 3 weeks ago, I was actually adjusting someone skin on skin. I had thrown some KT tape on their shoulder. They were having some TOS symptoms, and I just went straight for an adjustment after putting some tape on them. And I realized that I don't even know how to adjust skin on skin because there's so much extra friction in the skin that gets kind of lost in clothing, and you get less tissue play. Sometimes you get, just depends on the clothing type that someone's wearing, and you adapt to that really well. But even like in school, we never learned, even Gonstead is very big on tissue pools and skin on skin. And in the class, we never did any skin on skin technique. It's just kind of baffling that chiropractors are still so obsessed with that when in the clinic, rarely ever are they even practicing what they're preaching, if you will.
Yeah.
So I don't really get it. I just look for where stuff's moving and how it's moving, and if I can help it, then I help it. If I can't, then
there's this there's like this kind of idea out there, and I wonder if you would agree that there's a fraction of chiropractors that think that, you know, specificity is the ultimate goal, and achieving specificity is kind of like puts you above the rest. You know, like I don't want to say name. I don't want to go out there and call out certain styles, but we could probably all know what I'm talking about. But there's some techniques out there that think they're better than other techniques because they think they're more specific, right? They think that they are, you know, this part of the distal, you know, area of your index finger is literally touching the TVP, you know, or you're literally on the posterior arch of C1, or you're literally hooking on to the TVP of a
the lateral aspect of the distal tuft of the index finger.
Yeah, right. And there's this kind of like idea, like this kind of ego-based thing that like that is better, you know, because they're adjusting, and I've heard this 1,000 times, they're adjusting one bone, you know, they're moving one bone, and that specificity is what makes that practitioner better than the rest. And that's something that I find really interesting, because based on the research, you know, it can be up to the cavitation can be up to 14 centimeters away based on McGill's research.
I will say clinically, I've noticed that sometimes I do get better results when I use like a fingertip contact.
Yeah.
Sometimes I get better results when I use a more proximal, some contact up in here. It really just depends. Yeah, it really just depends on the patient.
Yeah,
but I would never use the same technique or the same contact on every single neck or body part, because it's not really patient. It's very patient dependent on what you're going to do, how you're going to do it.
Of course. And then obviously the whole idea of being able to put a bone back into place it's crazy because, with it's been 120 years roughly since D.D. Palmer, came up with this philosophy and whacked a bone back in place on what was his name? The janitor.
It was
There we go, philosophy.
I can see it. It's like
it's right there.
There's an L. If there's an L in his name.
Yeah. Anyway, and so he knocked the bone back into place, and voila. Anyway, we're 120 years later. People, after we had that fluoroscopy study, was it by Yoakum, showing the bone?
Yes.
By showing, and I've got a couple of other studies that I went through prior to this podcast as well. Fluoroscopy or MRIs showing the gapping of the joint.
It's Harvey Leelard.
Yeah, that's right.
That's it.
But we have these studies now showing us that you gap the joint and it goes back. There's an opening and then it goes back to normal. We're not moving a bone out of place or back into place. The structure or the integrity of the spine and the system of the body is a lot more stronger than that, and more resistant to that type of force. Otherwise, we've talked about this before, you'd kind of just fall over if you jumped around, or if you put under a squat rack, or even if you did like skateboarding or sports. Like, it's a very robust system. So why is this idea, everyone knows that the bone out of place model is outdated. We know that. Most chiros will openly say that, especially in New Zealand, because we have Heidi Havoc on site doing all the research. There's a lot of neuroscience forward thinking about what chiropractic adjustment is doing, but just not thinking about that right now, but just thinking about the bone out of place. Chiros are so easy to say that's old, but then, pretty much every single technique we have is based on aesthetic listing. So we're telling people that it's gone anterior superior to the right, and we're thinking that this is what the bone has done, and then we're contacting it here with the distal tip of the index finger, and we're pushing it back into place. That's kind of like the overarching story that that there's kind of trying to be portrayed. Yet we know that kind of the ideology of a bone being out of place is so old. What are your thoughts on trying to combat such an old thought process and ideology when it comes to your profession? Because you're a chiropractor.
So, yeah, I will add that in the Essentials of Radiology textbook by Yoakum and Rowe, there's a paragraph in there dedicated to discussing the fact that the bone doesn't go in place. And so I know there's a lot of chiropractors that will talk to their patients and tell them they have their hip was out, or they had a short leg or something. I don't really do that. I mean, I'm not going to bash someone for doing that unless it's creating fear mongering. Then it's probably not a good idea. It is a very kind of layman's approach to telling the patient what they're doing. So I kind of get it to a degree, but I just don't do that. I talk to them about their movement restrictions. I have them seated. I do a movement assessment before and after, kind of like a pre-post test on whatever I've manipulated and whatever kind of exercise we've built in, or any kind of soft tissue modality. I'm always doing pre and post check on how they're moving in general, or taking in an objective and subjective assessment, them telling me how they feel, me looking and seeing how they're moving, and combining that to see if we've reached our goal for the treatment, or if there needs to be more stuff addressed. That's kind of how I handle that as a clinician. I know there are some chiropractors out there who will try to indoctrinate their patients on the opposite and say that the chiropractor that they saw before wasn't evidence-based or not up to modern standards for chiropractic because they said those things. I don't even address it. Because at the end of the day, it doesn't change patient outcomes. It doesn't change my treatment approach.
Yeah. Don't you think that it can be problematic though when you're it goes back to communication, right? Where the line of communication is around, putting this back in place, or the patient thinking that you're putting something back in, or they come in and they say to you, my back is out, and you're like, oh, and you put your hands on them, T6, there's that bad, yeah, that's out, that the communication around that is out, it's like, or you're showing them x-rays and you've drawn up all these line analysis, and you're saying your lordotic curve is not what it should be. You've got a reverse curve in the cervical or the lumbar, and you're saying, you're telling the patient, like, this is probably why you're having pain. It's like, it goes back to like the biopsychosocial model, right? Like things are more complicated than that. So don't you think that type of communication can be damaging for a patient?
It absolutely can be. There's a lot of nocebo response psychologically to those ideas. And nocebo is the opposite of a placebo. Placebo is something good, like a sugar pill to make you feel better. And so a nocebo is the opposite. It's some kind of verbiage that makes you feel not so good. It has the complete opposite effect.
Like being told you're walking around on a short leg, being told that you're walking around 12 hours a day or whatever, 18 hours a day on a short leg, and like, doesn't that seem problematic for people? You walk in and the first thing the car does is, that right leg's short, and then they whack on it on a side posture, and then it's even now. But like, psychological impacts that can have on someone, right?
Yeah, honestly, whenever I hear you have a short leg, I immediately think of the episode in the show Friends where Rachel says she goes to your chiropractor and he says you got a short leg, and Ross and her dad are like, what are you walking around in circles? A short leg is definitely a functional thing, unless it's a structural short leg, like a natural anatomical leg length discrepancy. If it's not that, it's a functional short leg. It's a contracted quadratus lumborum or QL muscle. Lengthen that, but at the end of the day, it's probably going to shorten again because it's a functional adaptation. Exactly right. Most likely to driving a car.
Yeah, exactly. And the system is obviously it's an intelligent system, the musculoskeletal system, right? So you've got different types of forces being distributed through the body throughout different times, some asymmetrical, some symmetrical, probably more asymmetrical, obviously, but the body is adapting the best way it can, and sometimes that means you're going to have a functional short leg, possibly. I broke my finger when I was 5. I actually have a legit short right, and so it was always fun in class, and then in clinic when people would be doing Deerfields on me, because it'd always be a short right. And it'd be like, did a bang on a PI now, and it's like, no, some great thoughts there. I was scrolling through Facebook and I saw an interesting comment from you talking about spondies. So I'll just read this out real quick and then I'll get you to talk about it. If that's okay.
Okay. I hope you're not going to read that whole thing. That's kind of wordy.
I'm just going to read just the bottom part. I think just the meat. Okay. I'll leave out the beautiful humor at the top. So that's
okay.
people can go and read that for the ones that, if you know, otherwise you miss out. But pretty much more or less it says spondies, even unstable ones, can be and should be loaded to tolerance. Motor control exercise is a great way to begin and maintain core stability, but a spondy is absolutely never going to recover. So it's important for the long-term quality of life of the patient to be active and body conscious while also not fearful of exercise. So I really like what you're saying around that. I think it makes so much sense. If a chiro doesn't x-ray every PT patient that walks into the office, they have likely already treated a spondy, right? That's kind of where you're going with it. So, please do not scare. Please do not fearmonger people who have spondies. Absolutely, she should be empowered to gradually load her spine in a position she's going to need to use for the rest of her life to reduce flare-ups and just function as a healthy human. So, give me the summary of what you're talking about there, because I know you have a spondy yourself and you've had to walk through this as a patient, and you've got some opinions on it as a clinician too.
Yeah, spondies are very, very prevalent in certain demographics, most commonly with gymnasts and dancers and even young kids that played sports at a young age, like football or something like that. Anything where they potentially were hyperextending their spine over time while things are still developing, it's very likely that they may have a spondy. A spondy, for people that don't know, is a break of the vertebral body from the rest of the spine. And it sounds very scary, but it's typically not. It's usually very manageable. There are flare-ups that happen. Everyone, well, not everyone, about 80% of the population will have low back pain at some point in their life.
Yep.
And so low back pain, spondy has back pain, but it's a very specific type of pain that people with spondies have. So there's a little more kind of like structured, expected types of pain and discomfort with their flare-ups. But everyone at the end of the day is probably going to have back pain sometime in their life. And if you have pre-existing conditions, you're more likely to have back pain happen again and again. And so I don't know why spondies get such a bad rep. They can absolutely be awful. I've had some very bad flare-ups over the years, and mine was due to a car accident. So it was actually a macro trauma event instead of a micro trauma event. So it wasn't something that happened over a series of time. And eventually stuff that peaked out and didn't develop right. This was actually very traumatic. And so my initial onset symptoms were probably a lot more severe than most people's. But at the end of the day, doing anything was better than doing nothing. Getting out there trying to push on my skateboard again, no matter how painful it was, eventually got less painful. Going out there walking got less painful. Going back to a sense of normalcy in my life is what made the pain more tolerable. And since mine was traumatic, it was pretty low grade at first, and then like it was less than a grade 1, which is very minimal. It just basically means there's a fracture there. And then very quickly they found out that it was actually displaced anteriorly or in the front. And then symptoms came, symptoms went. I always had back pain, but that's probably also because I just have a lot of stress and I've been going, not nonstop since my accident. And I've had points in my life where I managed all of those stressors accordingly with exercise and other things, dietary stuff like that. And when I do those, the symptoms go way down. Even the regular pain levels drop tremendously down to very, very mild, like I'm talking 2 or 3. But at the end of the day, it's absolutely manageable. And I definitely get, if triggered, if you will, when I hear people say that spondies are basically people that shouldn't do anything at all with their lives. Because that's basically what I was told by a medical doctor. They literally told me at 19 years of age to just get used to living the rest of my life in pain. And that's not okay. Not okay. And so even clinician to clinician, when they're suggesting that patients, like this patient that I posted it on was a 14-year-old girl who plays basketball. And for clinicians to basically say that clinician should just have the patient accept that they're going to have a lot of pain and they should be fearful of all sorts of movements and fearful of exercise, is just extremely detrimental psychologically to a child or young adult or really anyone.
Yeah.
And so there was a very smart reaction, a comment from me at the beginning of it, because I was just kind of triggered, if you will.
Yeah. No, I like it. Makes a lot of sense. And that clip we put up of you talking about like a doctor saying you can't lift, or like a doctor telling you to stop lift last time had quite a lot of views. So I think a lot of people are in that position. I think they've been to a doctor or even a chiro or a therapist of someone that's just, doesn't understand biomechanics or training. And like you said, finding regressing to a point where you can then build from and rehabilitate from. People that don't understand that, clinicians or practitioners that don't understand that, are so quick to jump to just stop, don't train, get used to it. Almost similar to you, like just get used to it. Like I've been told similar things with injuries in the past. You're just going to have to stop and you're just going to have to deal with it, rather than giving someone actually a plan or a way to move forward so that they can get back to doing what they love. So, all right, cool. So I got a few questions through Instagram. I had a few comments and questions about tendonitis, mainly because probably I did a video on it recently, and I have part 2 of that video coming. But we can touch base on that real quick, and I can get your thoughts on it as well. I think tendonitis is one of those things that people think is more simple than it is, right? Like I believe it's more complicated than people generally give it credit for. I've had tons of tendonitis type issues or tendinopathy type issues as a strength athlete, and it is the most annoying thing. Not only is it painful, but it literally like saps all of your strength out of that specific muscle or joint or area of the musculoskeletal system. I had like tennis elbow kind of when I was strength training, and it would literally stop me in my tracks. It was the most frustrating thing. So I've had a few powerlifters and a few different type of athletes, people reach out and ask about that. Unfortunately, like there's no easy answer and there's no easy fix. And I think that's the frustrating thing with things like tendonitis or tendinosis or tendinopathy. In my video, I quickly shared some ideas around those terms, because I honestly, so many people get confused about it. Even between professions, some people talk about it differently. But based on the literature, based on what I've read about it, a tendonitis is an itis, so it's inflammation. Tendinosis is an osis, so it's kind of breakdown or degradation of tissue. And a tendinopathy can be usually used as a loose term for both, or can be used as something that is kind of ongoing and chronic. It gets thrown around differently. There's different ways to look at it. Does that make sense to you, Stephen? Like is that kind of how you look at it?
That's definitely common for people to mix up the verbiage, but yeah. I would say, like, from like a teaching aspect, because I have had to teach on this topic before. So tendonitis and tendinosis are classified as a subtype of tendinopathy, but a lot of times people use tendinopathy indiscriminately because either they don't know the difference between tendinosis and tendinitis, or they don't know how to manage one of the two, or they don't know how to diagnose one of the two. So they'll stick with like a tendinopathy, because tendinopathy literally means condition of the tendon. So they're like, yeah, there's something wrong with the tendon, let's just say that, instead of trying to identify if it's more acute in the tendinitis stage, or if it's become more long-term and chronic in the tendinosis stage.
Yeah, and the interesting thing is, when you look at the research, people have thrown out tendonitis for decades and decades and decades, and they've gone in and they've actually looked at this tissue under a microscope, and there's no inflammation present. And so it begs the question, are we dealing with more tendinosis than we are tendonitis? And then people say, well, yeah, it's an itis, so it's an inflammation, and then if you don't deal with it, it becomes chronic and it turns into an osis. But then there are further studies showing that it can be the complete opposite. It can go from, there can be osises moving in, like tendinosis moving into a tendinitis. So it's what the literature is showing us is it's not as simple as A equals B and B equals C. It's not like a linear thing. And so, like you said, the practitioner, the clinician really needs to know how to pinpoint what it is. How do we actually, for lack of a better term, diagnose this issue? And for so many people, they look at it as an overuse issue. But I know a lot of really intelligent clinicians and smart people look at it as a misuse issue. And this leads me on to my suggestion for people or athletes out there. If you're having an ongoing issue and you feel like it's a tendonitis or a tendinosis or a tendinopathy, really look at what you're doing. Really examine what is aggravating and what is causing it. And if you can figure out what's making it bad, in the words of Stuart McGill, you can hopefully engineer out that movement to the point where you've got a better movement, a more quality or high quality technique of movement under the barbell or the dumbbell or whatever it is. And you're able to kind of create a movement system that is pain-free. If you can do that, do that. If you can't do that, and I've been in this position before, I feel like my technique's good, I feel like what I'm doing is good, you need to look at your load over time, you need to look at your volume, your intensity, and you need to figure out a way to regress to a point where you're still doing something, but you're at a point where the pain and the damage is going to cease. And then at that point, the literature is, again, different on how you would approach an itis versus osis, but if we were to take a broad view, like a tendinopathy broad view, I know for me personally, when I was powerlifting, there were certain things I did that I would consider like a band-aid, like a quick fix. And they are things that I would suggest to people who are desperate to just get through. So, you know, you're 8 weeks into your prep, you've got a comp coming up, you need to get to the finish line. There are things that you can do to help you get over the line that are not, I wouldn't suggest technically to people, but if you really need to do it, you need to do it. When it comes to being smart about it, it's the stuff we talked about even on the last one, right? It's finding a baseline, it's building capacity, it's moving on from that to a point where you're pain-free and you can do what you need to do without having that constant flare-up or that tendonitis coming up. There's a lot of good research on isometric holds when it comes to tendonitis for actually helping with pain. So I know people will incorporate that before their training, and that will kind of give them a leeway or a period of pain-free movement. There's some studies now showing that may not be the best thing to do. It is what it is. We've got a lot of literature on eccentric loading. It is what it is. I know a lot of people don't like that now too. A brand new randomized control trial, a brand new meta-analysis of a bunch of control trials recently talked about progressive tendon loading. So a mixture of isotonic, isometric, eccentric, concentric, dynamic movement, different types of speeds of movement, pretty much putting everything into a program and then progressing it appropriately. And that actually had the best results when comparing it with other things. So for me, I would say, like, if you can, very similar to what we talked about last time, right? Find pain-free movement, find a way to move from there and then build the capacity and build your tolerance so you can get over it. Be patient. It's not, like I said, I feel like it's more complicated than people get it credit for. So if you're frustrated and you're really finding it hard, don't beat yourself up about it. Reach out and ask someone for help so that you can actually achieve your goals. It's not one of those things that is cut and dry. And it can be more complicated than people think. So, and then obviously there's passive treatments, and there's very little research to support things like cross friction massage, laser therapy, even icing. These type of things might help in the interim. And if you want to try to get yourself out of pain, then go for it. And then the things that I would suggest that, like I was saying to you before, the kind of band-aid things that I thought helped was definitely like icing the crap out of it, but then also mixing between ice and heat. I know heat can be sometimes aggravating, especially with inflammatory type things, but I personally found it was really helpful. And then also finding wrapping up. I would wrap up my elbow, and I would have like a tight compression band on it, and I would literally just like work through my working sets. And if I had to, I would even take like an NSAID, like an anti-inflammatory. And again, this is not what I'm suggesting you do. I'm just saying that you need to get through to, if you're going to get through to game day, you're going to get through to game day. So it's like wrap that thing up, ice it, heat it, take some anti-inflammatories, do what you're going to do. But if you've got time, do it properly. Anyway, what are your thoughts on that?
I agree with basically everything you just said.
Oh, good then.
Yeah.
Okay. Question for you. Okay, this is an interesting one. So Do you think adjustments help with powerlifting and stuff? Question mark.
That's a very broad, vague question, and
It is.
can it help? Maybe.
What are some possible mechanisms of why you think it would help? I suppose you could say an athlete
Yeah.
in general.
So obviously, adjusting the spine creates some neurological change. Neurological change, especially on someone like an athlete, or especially like an elite athlete, just the tiniest little change can help boost them above someone else. So neurologically speaking, they get like a leg up on someone by seeing the chiropractor. That's sometimes why you'll see, like, I know it's really common in golf and tennis. Those happen to also be fairly international sports, thankfully. But you'll see a chiropractor or physio on the sideline, sometimes manipulating the thoracic spine right before the athlete goes to serve or before they go to hit their golf ball. And just that little bit of neurological change can offset whatever they feel coming on just quickly enough to help with that very specific quick movement. So in the grand scheme of things, like, it may help over time when they're coming in for like maintenance care or if they're coming off an injury. But there is a very plausible chance that having like a manipulation seconds before performing a movement could put you at a better advantageous position than you were than not having it done. Just from the very quick neurological reset, if you will, like cutting the power off and cutting it back on to the brain, if that makes sense.
Yeah. There's even been some studies done, I know, with the team here in Auckland, with Heidi, where they looked at 18 Taekwondo students, and then also they looked at there's other ones as well. They looked at the elderly, adjustments on the strength of the elderly, strengths on athletes, and to make a long story short, they did find an increase in maximal voluntary contraction and V-wave velocity from my memory of the study, and they also found an increase in feed forward activation, so increase in proprioception input. But exactly what you're saying, right? It's a neurological input into the spine, right? So you're getting that neurological,
and it is very limiting.
benefit.
So it's not like you get one adjustment and you're like Captain America for the rest of your life.
Super soldier. It's the super soldier serum. It's getting adjusted.
Super Chiro serum.
That's an interesting concept, because we have all these great studies now coming out saying, hey, there's this neurological link to an adjustment. Like this old theory of bone out of place, pushing bones in place. We don't, it's not needed anymore, because there's a lot of new research saying, whoa, there's a neurological impact to the brain, like this possible maladaptive process that happens in the brain is linked possibly to these adjustments. But the one thing we just don't know is, like you said, how long-term is it? Is it long-term at all? And that's a very important question that we need to answer, because like many other passive techniques, and I would put an adjustment, even though I know a lot of chiropractors are going to be annoyed at me saying it, because they like to think that an adjustment is an active technique for some reason.
No, it is absolutely a passive modality.
It's a passive modality, and so it's going to have a limited time frame of impact. Would you agree with that? And what are your thoughts around adjustments having a long-term impact based on that kind of old school philosophical, that old school philosophical mindset or ideology?
If adjustments had such a long-term impact, chiropractors would be charging a whole lot more money, because you wouldn't be coming in as often. You wouldn't need to be coming in to see the chiropractor 3 times a week for your first week, or for 3 months, or something absurd like that. You wouldn't need to see him that often if it had that much of a long-term effect. The adjustment is a microscopic stimulus neurologically on a 24-hour spectrum of neurological stimuli. It's just a tiny bit. So far, at least that's what the research shows, and that's what makes sense. So until research shows otherwise, it's no different than me scratching my head right here. It felt really good right then and there, and that's it.
But that is polarizing to the more traditional philosophical view, right?
It can be, but that's also because their traditional beliefs are very contradictory against their own beliefs. So there's going to be some polarized opinions and beliefs on philosophies that contradict themselves.
Yeah. I mean, that's definitely another rabbit hole to go down, isn't it?
Oh, yeah.
Anyway, good. Question here. There's a question asking about bench, how to increase the bench, but it's so vague. It's really hard for me to give advice out on how to increase a lift, like on a podcast like this. I'm happy to go into more detail, like if people want to DM me and ask me a specific question, or I'm sure Dr. Stephen, you feel the same way if someone has a question that could hit you up or something. But
Absolutely.
it's hard to give these like overarching things. There's just 1,000 ways to do something, and so it's really hard. There's another question here about my top 5 powerlifters. So I can give you those. For me, I'll be interested to know if you know any of these, Stephen. Kurt Kowalski, he's an old school powerlifter. He doubled 1,000 pounds back in the day. He was an incredible squatter. I used to watch his videos on repeat before I would go squatting. So his name was Captain Kirk, and he's probably one of my favorite. More new school would be Ray Williams. He was a bit of it, he was epic. He's still doing it. Ed Cohen, love Ed Cohen. Stan Efferding, bit of a legend. There's so many. There's a lot of we got a lot of really good powerlifters in New Zealand as well. Brett Gibbs, incredible powerlifter in New Zealand. So we're really lucky. But yeah, do you have any favorite chiropractors?
I don't fan over anyone.
You're telling me, you're like not really a fan. You're just a fan of Marvel.
I am, but I could see Benedict Cumberbatch walking down the sidewalk, and I would be like, "There's Benedict Cumberbatch." I just
so
don't.
You don't
fanboy over anyone. I was like, "Oh, look, there's Bill Murray for the 59th time because he lives in the same town as I do." I don't get excited. Not even the first time I saw him, I was just like, "Oh, there's Bill Murray." Now I have my Bill Murray story.
It's Bill Murray.
Yeah.
And this question here, what inspired you to become a chiropractor?
My traumatic spondy experience and being misdiagnosed and mismanaged and talking down to by a plethora of healthcare providers eventually led me down this road.
Yeah, and then now you have the opportunity to kind of fill the gap that you saw in the medical system.
Yeah, that was my goal. My goal was to try to be there for someone when no one was there for me. So I want to help someone before they hopefully end up in the same situation or similar situations that I was in.
Yeah, that makes a lot of sense. No, it's good. Well, we'll conclude it there. Unless you have anything else you want to add.
I'm good there. It's pretty late my time anyways. Gotta get some dinner.
Yeah, I'm sure you've got a big week coming up.
I do.
Well, hey, thanks for chatting, and we'll do it again, and I'll put together some clips, and we'll throw them out on social media so people can have a listen in that kind of easy, digestible format. And then this podcast will be available on Spotify, iTunes, and YouTube. Sound good?
All right. We'll catch y'all later.
Sweet. Shot, man. Have a good one.